discussion, which is really we're going to say about implications for treatment and just a general discussion. We have a number of questions too that had come in for individual presenters, and there may be other general questions people want to ask as well. One of the questions that came up in the individual presenters' questions and in some thoughts some of us and some of the NEA folks jotted down are the issue of specificity. You know, we talked about mood disorders, anxiety disorders. We talked about, for example, the FACES paradigm and other disorders, but certainly a model of cortical or frontal hypoactivation, amygdala overactivation has been posited in anxiety disorders. Affective disorders. What are some of the potential differences or the kinds of things that could be tested for differences between borderline, severely depressed patients, antisocial patients who aren't borderline, just effects of nonspecific stress in medical patients, PTSD? Any comments? Of any of the biomarkers of them are the models?
I think up till now, very few studies have looked at psychopathological control groups, so that most of the studies have looked at borderlines compared to normals, and there haven't been many studies that look in the same study at borderlines, depressives. So I think from the point of view of data, there really isn't that much data on that.
Well, I can comment on that a little bit. I mean, in the work I do, we have, aggressive personality disorder patients, and we've got non-aggressive personality disorder patients, and we've got normals. And almost all the time what you see is a stepwise thing, where whatever you're looking at, maybe much higher in IEDs than the controls, and they get something intermediate in the other guys. And then it's a power issue, how specific it is. Because, patients that are other personality disorder patients with a psychopath control, not psychopathological control, is always going to look different than the normal. The question is how different is the group you're really interested in looking different than active psych controls. You need a lot of patients to show a difference in the psych controls in a group of interest.
I think it's a difficult question, and I think the question spreads into the idea of comorbidity. I think all of us see in our studies borderline patients who have comorbid disorders, because if we looked for borderline patients who had no comorbid disorders, we wouldn't have any patients. So that leads me to consider that maybe there's an underlying vulnerability which actually leaves one vulnerable to borderline personality disorder, but also to other disorders, mood disorders, substance abuse disorders. And so there's an underlying general vulnerability. And actually the field of psychiatry has come to understand that there are probably more general genetic vulnerabilities to disorders per se that are not specific. So I don't think the question of specificity falls only in the lap of people studying borderline personality disorder. I can say that from the specific data that I can think, I have not run across other studies that have shown hypersensitivity to neutral affect, to neutral stimuli. So that strikes me as something that does certainly distinguish borderline personality disorder from sort of major depressive disorder, but we really are very, very short on data about comparing this disorder to others, as are every other diagnosis in psychiatry.
I think that we will have some data soon, actually. We're starting a study comparing bipolar patients to borderline patients and using normal controls. And in another study, some of the emotion regulation work that I talked about this morning, we're going to extend that to a personality disorder group, avoidant personality disorder patients who are responsive to interpersonal situations. But we think that there are different mechanisms that are involved.
Into the bipolar requirements or?
Yeah.
I think one of the problems here is that we've been talking about categories all morning, borderline personality disorder, intermittent explosive disorder, when another way to approach this is to look at these as behavioral dimensions, which cut across the whole population, and dimensional severity in affective dysregulation or impulsive behavioral control. The biochemistry belongs with the dimension. Dr. Siever has referred to these as endophenotypes in his writings, and these are most closely linked to the genetics. So we're looking at dimensional traits that cut across multiple diagnoses. In the future, I can envision a time when the term borderline might disappear, and we might be talking about the specific endophenotypic traits, that is a disorder of affective dysregulation or a disorder of impulsive behavioral control, and its own biochemistry without the categorical label.
I mean, I think I'd like to say the categorical labels really have relevance more to clinical medicine. I mean, you know, we sort of need to label people as having something as given the medical model, which is diagnosis sort of leads to treatment. But even in things like diabetes or hypertension, which is certainly in blood pressure and glucose are dimensional, they're very dimensional, and they're purely dimensional. I mean, the difference between a blood pressure, the difference between 90 and 100 for blood pressure is the same as the difference between 120 and 130 in terms of the numbers. But at a certain point, you get into trouble, and that's really what it is. But it's not really different. Something unless you've got some kind of genetic, you know, something like, you know, point mutation or something. If you're talking about essential hypertension, for example, it's just the total dimension, and we call people hypertensive when they reach a certain point because we know that people are going to get into trouble with that. And it's the same thing with these dimensions. You can have affective lability, some degree of affective lability. It's only when you get to a certain point that you get into trouble because of it. It's hard to believe that you know, there's only some group of individuals that, you know, have this, period, and that's, you know what I mean?
I'm going to challenge my colleagues to address the factor structure question. Because while I tend to think dimensionally, in fact, the data show that it is a unified construct, that these things run together. They don't simply run, they don't segregate independently. So if that's true, you know, how does that, you know, how is this disorder going to disappear and just have, are we going to have an impulsive aggression and affectively unstable? I don't think so. I think these things run together not by happenstance, based on the factor analysis.
Even if you have correlations, they're not, well, actually, the correlations usually are extremely
0.99.
No. The correlations usually are extraordinarily high, although I haven't really studied that area of this.
Yeah, no, but that's what I'm saying, is the phenomenologic data that have studied thousands of people show that these things can form together. And I do agree that the neurobiology has been best simplified by dimensional studies, but I'm not sure that's what's out there.
Well, if you look actually at our practice, at our clinical pharmacologic practice, and Paul Soloff can certainly talk to this, there's been a shift from treating people choosing the medication based on the diagnosis now to choosing medication more based on individual dimensional symptoms, certainly at the current state of our knowledge in treating borderline patients. Whether that will remain, but at the present, we're actually operating clinically more on a dimensional level.
So maybe that segues into just a more general question about treatments. There are questions about what do we know about what does work in borderline personality disorder and in what context, and what implications do the kind of work that people have talked about today have for future interventions. I guess a broader question someone asked is how has what people talked about today going to help consumers who have this disorder or have a family member of this disorder in terms of treatment, whether pharmacologic or otherwise?
Yeah, let me start with that, again, to follow what we've been saying about the pharmacologic treatments. Many studies now have shown some benefit of varying medications against these target symptoms, affective dysregulation, impulsive behavior, some of the cognitive distortions. Many studies have shown efficacy. And these are, again, the biologic targets. The studies that have targeted interpersonal pathologies, dialectic behavior therapy, show similar kinds of effects against symptoms generated from interpersonal conflict. So I think approaching the problem dimensionally with highly selective treatments has produced some effect. The difficulty, of course, in research is that no one does everything with every patient. We have yet to see a study that has multiple pharmacologic treatments combined with multiple psychotherapy treatments in the same patient population. What we do then is we choose one drug or one psychotherapy, we pair it with a control, we show some improvement, but obviously the patients are not entirely well. In the best of my own studies, for example, when we treated highly depressive patients, borderline patients with a lot of mood instability, at their very best, and they felt better, statistically significant, but they felt clinically better. If you examined them carefully using rating scales, they still had a considerable amount of depression. The joke around my department was that they still had enough depression to qualify for my depression study partner entering them into his protocol after they were successful in my protocols. So we succeed up to a certain point, and the patients feel better, but they're not 100%. They're not remitted by any means.
I think there's a further problem, which is that all of us, I mean, it's not exclusively true, but generally you have here a team of people doing neurobiological studies to try to elucidate the disorder. And the people who are the most ill don't enter our studies because they have things that muddy the water in terms of the biological signal, like substance abuse. And also, I think from my perspective, clinically, the greatest challenge is actually getting people to commit themselves to coming in and doing and working effectively at becoming better. I mean, and that takes, from my experience, often years of a lot of symptoms. So it's a hard path to get. I mean, first of all, we're not very good at treating people. If we had more effective treatments, I think we might be more effective at bringing people into them. But I also think that there's a fair amount of complexity in the clinical presentations that make us need many, many dimensions of treatment that make it too hard to do research because too many things are thrown in the air. So that's why we don't do all the same things in many different things in one patient.
Well, it's certainly true. I know that when we do our treatment studies, these impulsive, aggressive personality disorder patients, they may not be the most severe aggressive individuals. I mean, they're not people who've been in jail and that sort of thing. But even there, only 60% finish a 12-week trial. And in point of fact, if our understanding of that aggression and how you treat it is true, these people need to be on these drugs all the time. Because when they come off the drugs within a month, they're back to where they were. I mean, this is sort of a trait, and so they need to be on the treatment all the time. And you can only get 60% to go to a 12-week study. It makes it hard to do that. So a lot of the people, when I was on the airplane coming over, and the person next to me, we got into a conversation. So what do you do? I said, well, I'm a psychiatrist. And he said, well, what do you do? And I said, well, I study aggression. And that sounds interesting. And so she thought that the people I study are these, monsters who beat the crap out of people and, belong in jail. And I said, well, actually, they're more like your neighbors who are hotheads. And so, we don't, whether you can generalize our data to these very severely aggressive individuals, I'm not sure, because if that very small data set showing that the more aggressive you are, the worse your serotonin system is true, and that you really wouldn't respond to these SSRIs, then that could mean that these very severely aggressive individuals are going to need totally different kind of intervention to get them better. So that's another thing that makes what we do differently than what's in the real world.
So I wondered if even somebody could summarize, or a couple of you could summarize, what do we really know about efficacy, and what aspects do we know can be treated in borderline personality disorder, say from a pharmacologic point of view? And second, what would be the implications of this research for selecting an appropriate individualized treatment plan for specific patients on a sort of personalized basis?
Well, part of the problem is that drugs from different classes may have a similar benefit. For example, you can treat affective lability in a borderline patient. It responds, but it responds to the same anticonvulsant medications that may be used in bipolar disorder. It may respond to lithium carbonate. At the grossest level, you can use neuroleptics to dampen down affective lability. So you've got three different drug classes. some of the SSRI medications may help, maybe 4 classes of medication, all of which may be helpful in this one behavioral expression of pathology. Now, is that because they all, to some extent, operate on the biochemistry of affective lability? Probably, at some level. And you can go symptom by symptom. What gets better? Affective lability is definitely treatable. Impulsive aggression is treatable. No, treatable. We can moderate the symptom expression. We can get, in the scales that I've used in my own research, 30-40% improvement is the best you get in most of these scales. Depression scales, Hamilton Rating Scale and Beck Depression Inventory, about 30-40% improvement with SSRI antidepressants. Yes, you can get improvement. The patient feels that, by the way. It's not just an empty statistic. But when you actually measure, you say, oh my God, it's only 30-40%. It's better than nothing, and as I say, the patient feels it.
But also the relationship between symptom improvement and functional improvement is not necessarily linear. So even a 30-40% improvement is certainly true for depression, can lead to a much bigger than expected improvement in function. People may be totally dysfunctional, and you get 30-40% improvement in their symptoms, and they can start to actually do
Also being able to predict which patients will respond to which medication is something that we can't do right now, and one tends to try one medication and maybe 30-40% of people will respond to that, and if that doesn't work, try another medication. And I think a really important direction for our research could be to identify predictors, whether they're genetic predictors or neuroimaging predictors, that could tell us that, this patient has more amygdala hyperexcitability, and then that one individual might respond more to a mood stabilizer. This person has less activity in the orbital frontal cortex, and they might respond more to an SSRI. I think this is one direction that our research really should take, because now we're looking at heterogeneous populations, and so there are probably a mixture of subtypes, and they respond, some respond in each medication trial, but we may be able to identify the subgroups that would respond to the specific medication.
My guess is that's going to be a clinical subgroup more than a biologically based subgroup in my view. But I think it's important to say that nobody's saying, which is there have been, Larry asked us to summarize, it's pretty clear that SSRIs help with mood stabilization. It's really clear from Mary Zanarini's study that olanzapine helps with some degree with mood stabilization and with impulsive aggression. Mary also did a recent study looking at olanzapine plus fluoxetine and fluoxetine alone, and it's pretty clear that olanzapine is superior to fluoxetine in a broadly construed group of patients with borderline personality disorder. I think we pretty much know that that benzodiazepines are not beneficial. I think we pretty much know that we use with relatively little evidence antipsychotic medication other than olanzapine. Early study of yours used Trilofan, did it not? And there was some benefit. Oh, Haldol, okay. And there was some improvement, particularly with patients who had some psychotic symptoms. And so I think, there are good studies. There's actually good, Mary did a very good study using omega-3 fatty acids and showed an improvement in mood and an improvement in impulsivity. So I think there are empirically based studies that take us just so far. So far, nobody has really had enough people in their study to look at clinical features that predict outcome that well.
Yeah, it's also really an interaction between the drug and the particular features of the patients. This is really highlighted in Paul's early studies, where in either the first half of the study, Haldol I think really worked well or something, and in the second part of the study, it didn't work as well because whatever it was, but it was like in the second study or something, there were less schizotypals, and so, which can be comorbid with BPD. So that's something we keep forgetting. It isn't just BPD you're treating, but there's almost always something else going on there, and if it's schizotypal. So I think Paul's studies, and I'll let him speak about it because he did though, sort of speak clinically. I think you've also worked on algorithms clinically based, which you should talk about.
Well, what we tried to do was to look at symptom responses, look at the response of impulsive aggression, or look at responses of the affective mood symptoms, and go through the literature, including my own studies, and see what would be the treatment of first choice, what would be the treatment of second choice, and so on and so on. recognizing that only the first step in any one algorithm had actually been tested by double-blind studies. And these are published and in the literature, so that people can see what clinical guidance looks like when you have some research evidence for at least the first choice drug faced with a particular symptom pattern with borderline personality disorder. Again, these only treat the so-called biologic symptom presentations. They don't do anything for interpersonal relatedness. The interpersonal relatedness may improve once somebody has control over their feelings or their impulses or their aggression, but to treat the relatedness issues, you really need psychotherapy. And the medications by themselves, I've never seen the medications purely by themselves produce an effect that turns around somebody's life. You really have to have psychotherapy with it.
Well, one of the questions actually addresses what I think Antonia mentioned. What do you think about subclassification of BPD or BPD spectrum disorders? I guess the question would be, would there be discrete subgroups, or would this be really dimensional and individualized? And then what about individuals with borderline-like symptoms which manifest only under specific environmental circumstances and high levels of stress, or somebody who's in a dysfunctional marriage or family appears borderline, and then when that changes, their picture changes in an enduring way. So those are part of one question we got.
My thought, though I'm reluctant to share it, is, well, then they shouldn't be in that marriage. I mean, that's to be flippant. I think we don't really have the data to know whether there are subtypes. I mean, the large data from large collaborative studies with thousands of people suggest there really are not distinguishable subtypes. On the other hand, there are medication studies that target specific symptoms. So I quite agree with Dr. Soloff and Koenigsberg that, we treat the dimensions because that's what we can target successfully. We haven't really understood what the underlying disorder is yet. And when we do, and if we have a specific symptom, a specific neurobiology of that, that will make huge headway in our field. We're not there. So we don't have that, so we work with what we have. And at this moment, I think there are not clear clinical guidelines. I mean, there are guidelines from Paul's work that suggest if somebody's affectively labile, certain drugs will help. And so I think clinically how we all approach it is we try to target those symptoms in accordance with those guidelines, and sometimes it works, sometimes it doesn't, and we shift. And I think that's sort of where we are, but I'm not sure we're ready to do subclassification yet.
I would agree. I think we're far from that. The other thing is it's true for depression and anxiety disorders. I mean,
Yeah, that's the same.
Just because someone has depression doesn't mean they're going to respond to an SSRI or the first thing you give them. And so, I think sometimes BPD gets a bad rap in terms of treatment responsiveness because, maybe the garden variety depressive responds to an SSRI pretty easily, but there's a whole lot of depressors who don't. And they're in our practices because they're not responding to the things that are, generally tried first. And that's, part of the stigma. I remember when I was a resident, and I was a resident here at Sinai in the early 80s, borderline was pejorative. We would sort of kid each other, like, you're such a borderline, And it was pejorative. And in fact, when Larry was coming up with the VA from NIMH and I was going to work for him, he told me, I was interested in mood disorders at the time, and he said, there's biology of personality disorder, and I just sort of, I didn't say this to him on the phone, but I was like, what? There's no biology of personality disorder. What is he talking about? This is all just crap. But it's not crap. And it's something that unfortunately has been stigmatized. There's enormous amounts of data in the last 20 years indicating that it's a serious condition that has a lot of ideological factors to it that need to be paid attention to.
I have to say, in treating, I was referred a patient with quite treatment refractory depression, and it was interesting because the uniform response, he then went on to go to another city for school, and from both the person referring him to me and the person I referred him to, the question was, well, he's not responding to any medication, so he must be borderline, right? And I thought, whoa, this is flipped on its side. He actually, in my view, didn't. He had a very treatment refractory depression. But this told me something about how the general field views our disorder, this disorder is being basically one we can't treat. So if a patient can't be, therefore if a patient can't be treated, they must be borderline. I mean, it really is a problem of education, and I think continuing medical education in psychiatry, because I think Emil's right. I mean, there's a tremendous amount of treatment refractory depression and other things, and it doesn't necessarily stigmatize all borderline. You have a question? Yeah, let's give him a mic.
Come up here.
Yes, absolutely. Come on.
Yeah.
So for last year's APA, we just looked at the 21 placebo-controlled studies, not looking at various other drugs. So when Paul did his studies in the late 80s, we didn't include that, well, because it involved both amitriptyline and haloperidol. But basically, one of the things that was frustrating to us, and we took Larry's 4 biological dimensions and tried to see whether or not, well, what drugs work for this dimension, what drug worked for that dimension. And when we looked at something like emotion affective instability, I guess is the phrase that Larry used, there were 21 different words that people used in the papers that they then said were equivalent to emotion dysregulation, and those were measured by 23 different measurements. So you can have somebody looking at, there's the IMPS, the impatient, it's an impatient aggression scale, and then the overt aggression scale. You can look at the Bus-Durkee, you can look at the BIS, and everybody then says, well, that's a measure of aggression, and obviously it's a measure of different aspects of aggression. So I feel like we run around in circles, and we need to have a committee get together and say, back in the early 70s, we had research diagnostic criteria. Antonia, that's what the Gouze stuff was about. We need to have research outcome criteria. So we need to decide if we want to measure affective dysregulation, how are we going to measure it, how are we going to define it, and let's all use the same measurements so that then the results that one person has can build on the results another person can build on that. Because each time it's like reinventing the wheel, and I don't know how to go from the findings in one study to the findings in the other, because the words are different and the scales measuring them are different.
I want to say 2 things there, because I agree completely, and I would advocate that if we have such a committee, that we include a measure of psychosocial functioning, family, interpersonal, a whole bunch of things. But the other point I would say is that I've done a little more work in depression studies recently, and they also have a gazillion forms. And even if you look at the Hamilton alone, the question of whether you use the Hamilton 24, 21, recently 12, I mean, there are so many different, the 6, exactly, there's so many different forms that we aren't talking to one another. And I think that's, that makes the studies very hard to compare to one another. I think that's a problem in the field of mental health.
Some of us were part of a BPDRF sponsored effort to try to put together sort of a whole genome association kind of study, and we faced that with us, and that's why I was sitting here listening and good luck. I mean, we were all using different measures. I mean, some of us were using same measures, but more than not, we were using different measures for diagnosis, certainly different outcome measures. And we'd sit there and we would, it was a very genial and civil discussion, but it was clear that people had their pet measures, and and there wasn't really enough data to really say that this measure is really better than this other measure, and
we're going to do the same thing, though, Emil. We're going to agree.
No, well, you and I could probably agree, but getting, somebody else to agree might be hard. But
I'm going to force them if they're part of this study.
Well, honestly, actually, if the infamous NIMH would go after this the way they've gone after certain other things and form collaborative, put money into a collaborative study, then we obviously have to. I mean, part of the problem with BPDRF is that it's not clear we're going to go forward with this, which certainly hurts it.
It's a foundation. They still don't know what it is.
It's the Borderline Personality Disorder Research Foundation, and they did a lot of good work, and some of the work we presented came out of that, but it's not clear where it's going for its next steps, and it's unclear if this study that we were going to do across countries is ever really going to come off. Yeah. But you need stable funding to be able to get enough investigators to really get together and actually make those decisions.
Well, I think we're facing an issue where there probably is a lot of individual variability in dimensions. It's probably not going to parse out like subtypes, and how we even parse those dimensions and what measures we use is hard to validate in some satisfying empirical way that you're exactly parsing, or carving nature at the joints. So there's a certain amount of historical and consensus-based requirement for uniformity that doesn't have an absolute validator. But I think it's unlikely we're going to get specific subtypes, but I think we are going to get combinations of dimensions to think about individual response. I think the BPDRF initiative to look at genetics, which it looks like it's going to go ahead, but it's going to be a start, is not going to be able to sort of definitively answer treatment response issues, the kind of ends you need for these kinds of things, maybe as many as 10,000 people, and that's just for the association. Then when you're looking for prediction of response, this is a genetic level. I think we have a better chance with using some of the biomarkers.
But Larry, even in our own studies, looking at, we were funded to do, from the Borderline Personality Disorder Research Foundation, to look at endophenotypes. And in fact, one of the difficulties in our analysis is that they are highly correlated with one another, which is what the factor analysis said. That's really what we found. They don't separate.
Well, except actually what the findings said were the self-report scales, and this is something that I think you, Emil, or one of the two of you, I think, presented. Yeah. When you look at the clinical scales for borderline, even for different dimensions, you find very, very high correlations. Whether it's affective instability, whether it's ingression, they seem to all be run together. Of course, you're selecting people for being borderline, but we also get people with other personality disorders, so some of these traits are distributed. On the other hand, for some of the lab and behavioral endophenotypes, what you saw was less specificity for borderline, but greater separation, like we could separate between impulsivity and aggression, lab pays better. So what you're going to get, if you get down to the level of endophenotypes that are closer to genes, is that you're going to account for less of the variance. You're going to be able to explain less with any individual endophenotype or gene because it's going to be less specific for borderline, and it's going to capture less of the whole of the construct. But it may help you parse out some of the underlying neurobiology and genetics. I think we have to sort of recognize there's a trade-off, that the sort of high-profile things we all agree is central to borderline and are specific to borderline are not going to be particularly distinct from each other. They're all going to converge, and that when we start teasing these things out, we're going to get the factors that may run across disorders and cover dimensions, but not be as specific for borderline. So when you do get closer to underlying neurobiologic substrates or genetics, then by definition, when you're breaking down the syndrome, you're losing the syndromal whole. But the hope is these are going to be tools to get to thinking about more effective treatments or ways of approaching the disorder. Endophenotype, I think Paul mentioned, phenotype is a manifestation of a gene coming from genetic studies like that of Granger-Mendel, where you look at the, say, number of Ps or the quality of the Ps, and then you can cross different types of Ps, and you get different phenotypes, and you can infer information about genotypes. Endophenotypes would be phenotypes that may not be as visible. They may be physiologically measured, they might be biochemically measured, but presumably they're closer to the underlying genotype. I have another question here. Dr. Koenigsberg mentions Suboxone. I think you had mentioned buprenorphine. Christian Schmahl mentioned naltrexone for dissociation. The self-medicating hypothesis of addiction presents that opiate addiction is related to anger processing problems. Would opiate-related medications possibly be appropriate for dissociating BPD patients, after they obtain sobriety? And is there research on this use of these medications?
I don't know if I get the question correctly, but I don't know. I'm not aware of any study that is looking at the opioid medication after sobriety in BPD patients. But what does it mean to dissociate patients from what?
No, would these medications be appropriate for borderline personality disorder patients who dissociate?
Who dissociate? No, I don't think so. I mean, that's naltrexone has been tested by us and others for the treatment of dissociation, but I'm not aware of any other studies looking at Suboxone or methadone.
Well, there have been several studies looking at naltrexone and self-injurious behavior.
Right, of course.
And there's certainly anecdotal studies that patients respond to and even seek, in some instances, Vicodin and some of the agonists. So there is some data suggesting some imbalance of the opiate system, which could, in fact, if you look at preclinical work in separation distress and emotional reading, be related to some of the emotional disreading, mistakes, sort of hyper acuity and hypersensitivity, and also some of the separation distress and the sort of baseline feelings of abandonment and dread. So it's certainly a system that can be looked at. It's not terribly easy to do these kind of studies, particularly with mixed agonists-antagonists, because of concerns about addiction in these populations. But it's certainly an area that should be further explored, I think.
There are some studies now that are just getting underway looking at buprenorphine, which is a mixed opiate agonist-antagonist, for treating depression, with the idea that by activating the dopaminergic pleasure systems, you can treat the anhedonia component. But as far as I know, no one has looked at that yet for borderline patients.
Question about prognosis, maybe we could discuss that. What about in younger patients, in older patients? Does anyone want to tackle just some of the issues for prognosis?
I think just to report, again, what Mary Zannarini has published from her longitudinal study, that any given cohort of borderline patients, I guess as many as 88% now, as Antonia presented, 88% will no longer be eligible for that diagnosis after 10 years. So that's good news. I mean, that's the best news that I've heard from this research in a long time. Now, what Dr. Zannarini does is look at the state symptoms. And, well, she looks at all the criteria, and what disappears are the state symptoms, the angry outbursts, the impulsivity, the suicidal behaviors. One could argue that the underlying character or the underlying personality structure has not changed, but still those folks are in a lot less distress than they were before. So that's good news, I believe. So the prognosis for suicidality for that 25% or 12% that doesn't change is still pretty grim. As I said, my own study, which is longitudinal and underway, we have about 5% of mortality already, mostly by drug-related overdoses, one by hanging, but 5 deaths out of the 218, I believe. So our numbers are beginning to creep up, I'm afraid, and the range of 3% to 10% mortality is probably accurate.
I also think that prognosis depends on where you're treated. You know, one of the things that I'm struck by, I mean, we've talked about some of the pharmacologic studies. There are clear evidence that there are psychotherapeutic studies that are effective, and those I think are going to be the focus of tomorrow's talks. But and clearly DBT has been well studied. But it's also true that that if you live in certain cities in this country, it's going to be very hard for you to find adequate treatment. And if you live in other places, I mean, if you happen to be lucky enough to live in Boston, you're going to have a better prognosis, in my view, than if you live in other cities that don't have adequate experts in the field. And that tells me that we there are a couple of reasons for that, I think. I do think that Mary's studies are so positive in part because I think people at McLean are treated very well. Now, that doesn't mean all the symptoms go away, but I think they're very, very good. And I don't think that level of treatment is available throughout the country, partly because it's hard to do, it requires a lot of expertise, it's expensive. And we have not successfully advocated for adequate medical coverage for any psychiatric illness, let alone BPD, which is a very expensive illness to treat. So the prognosis is not done in a vacuum. I was recently at McMaster University in Hamilton, Ontario, giving grand rounds, and they have an amazing BPD program there with DBT and real expertise there. And that's all free for their citizens. Now, it's also true that if you live in Hamilton, Ontario, you're lucky. There are other places in Canada you're less lucky. But, you know, my sense is that it depends a lot on who's treating you, what your prognosis is, I'm afraid.
Another question. In your opinion, how does the psychobiologic research support or refute the psychodynamic explanations of the disorder? Do we understand the brain functions enough to know which comes first?
I think we're at a point where we can look at correlations, where we can find associations, but not look at causality, which causes the other. I think some of the data that I presented this morning about the ability of people to detach from emotional cues, which we saw that the borderline patients had more difficulty with because they couldn't activate those regions of the brain as well. That ability to detach is a concept that's related to one of the psychoanalytic concepts of isolation of affect, the ability to kind of withdraw your affect. Another of the psychodynamic concepts, the concept of splitting, the difficulty in keeping in mind two conflicting views of the same person, may be correlated with difficulties in processing conflict in the systems in the brain that process conflict. So while these ideas are very preliminary and very speculative, I think that we can begin to move in the direction of looking for correlations between what's going on in the brain and what's going on in terms of the psychological processes, because after all, they're all connected.
Here's another question. How can the treating professional obtain the interpersonal information Dr. New points out is missing? Can information from families be considered?
I can answer that. I think, you know, clearly information from families is essential, but it's also important to have the trust of your patients. So in my approach, I get the information from the families with the consent of the patient, and periodically touch base with family members. But it's a careful balance. You have to be incredibly, I'm very clear with the family members. I say that, and I'm very, very upfront, that I say, well, I want to hear information from you about so-and-so. I'm not actually going to tell you much unless I think it's an emergency. And I'm doing that with permission. And I catch my patient up on the information I've heard in a very open way. And I think that makes it tolerable to people. But I'm very clear also that patients themselves aren't necessarily so good at telling me how their interpersonal relationships have been going, because they're in the throes of an affective state at the moment they tell me. So they might have had a pretty good week or 2 weeks. But then, you know, it turns out they feel terrible at that moment, and then I haven't heard. So I do think having what is not nicely called an informant is useful, but I think it has to be done very carefully.
Yeah, but also the informants may not be able, are not going to be able to be in a position to tell you what they've been doing every moment of the day for a week, number one. Number two, they can't report so much on intrapersonal kind of events and feelings. So you really need a complement of the two, and you have to also take into account the veracity of both the informant, the patient, and the family. There could be agendas that'll alter what they're saying.
This also connects with the previous question about the psychodynamic approach, because the and you'll hear more about this tomorrow, I think, when Frank Yeoman speaks, but a key principle of the psychodynamic treatment is to use transference, which is to observe the actual nature of the interpersonal interaction in the room. And that is an extremely powerful source of data, because you can actually observe what's happening interpersonally with your patient in the room. And that may be, certainly an extremely valuable source of information, maybe more reliable than informant information or even historical reports.
I was about to say that, that the problem with that nowadays is that you may not see your patient frequently enough to have a really good snapshot. In the days when people were seeing somebody 5 days a week, there was a different sense of keeping your finger on the pulse. I certainly don't do that sort of treatment. I'm not trained as an analyst and certainly don't. But I think it's a little bit hard to use transference as the only information source when it's not that frequent that you see the person.
Well, yeah, and actually in transference-focused psychotherapy, patients are seen typically 2 times a week, and you can use transference at that frequency, and that's really not out of the ballpark.
Another option is that ambulatory assessment that I mentioned this morning. So this is a great opportunity to assess interpersonal situations. So we use that to ask, to prompt them to report in certain interpersonal situations if they have troubles with their neighbors, spouses, or whoever, and to respond to, and they are asked what emotions they had, how intense they were, and so on. And so this can be used as directly used for therapy then. So you can assess that over 1 week or so, and
Event contingent recording is very similar to that, Moskowitz's work. And that's a way to do it. I would say the reason I didn't answer that is because it's pretty labor intensive to have a clinician. I mean, it would be an interesting thing to do. I think we need to do it, but these things are not widely used by clinicians at this point.
That's right. So you have to use some automated readouts so they can read out the curves over the week for the emotions or something.
Otherwise it's a lot of data.
There's a question I think people touched on earlier, but maybe we could have some comments. Does borderline personality disorder in an individual intensify perceptions of trauma and abuse, or is a borderline personality disorder a result of abuse? And how do these concepts correlate with differences in the volume of the brain components and amygdala?
I mean, that's the most important question in this domain. So most of these studies, the epidemiological studies rely on self-report measures. There are only a few ones that really go back to a chart, and even then, mostly there is no chart about sexual abuse. And so we have no better database so far. So it's not clear whether it's really related to the perceptions or to reality. We can't solve that question now.
Yeah, I mean, I think that the more objective data comes from the abuse literature from a cohort of children who've been abused to look at whether they then develop borderline personality disorder, and overwhelmingly they don't. So that means that it isn't just abuse. That doesn't mean abuse doesn't play a role, and we don't have the data to really define that as Christians.
Just one caveat to the discussion, and that is that you shouldn't fall into the illusion that adults reporting abuse are exaggerating or falsifying past histories. Studies have been done comparing current histories obtained from adults who had been adjudicated as children with court records that documented the nature of their physical or sexual abuse. And the historical data obtained from the adult many, many years later was found to be accurate in about 70% for the details of the abuse. So that's a pretty good number from an adult informant many years later.
Some questions about some possible environmental biologic factors that maybe the experts can comment on the data. What about mercury, thimerosal, the vaccine issue I guess they're referring to, and the other is diet, sugars, fats, low-fat diet. Do these have any impact on development or treatment of BPD? Any data?
I think the data is pretty clear that we don't know. There's almost no data. I would say that I would reiterate Mary Zanarini study using omega-3 fatty acids, which improved mood stability and decreased impulsivity, giving high doses of omega-3 fatty acids. So that's a nutritional supplement. I don't think we really have any other data. I know of no data on thimerosal. I know no data at all on mercury or any other such thing.
The omega-3 fatty acid literature came out of the observation that in cultures where people ate large quantities of fish, there seemed to be lower incidences of depression. So there is, certainly are potentials for environmental factors.
What accounts for volume reduction of specific brain areas in people with BPD? Any evidence that these volume changes are reversible, post-psychotherapy, with medication, remission, etc.?
There is no evidence if they are reversible, but maybe if we start with the first question, what accounts for the volume reduction? So there are two possibilities. One is the cortisol hypothesis, that repeated stress, increased cortisol, leads to destruction of hippocampal and amygdala neurons. That is the hypothesis that was put forward in PTSD. But there is also the alternative hypothesis that people that were born with smaller brain volumes in hippocampus or amygdala have a higher are in danger to develop these disorders. So for BPD, we don't know. For PTSD, there are starting studies that looking at twins that develop PTSD. One of the two twins that develop PTSD, the other doesn't. And that seems to be a pretty strong genetic influence for people that have smaller hippocampi to develop PTSD when they are traumatized, as opposed to those that have larger ones. This speaks for a genetic predisposition for someone that has, for what reason or at all, has a smaller hippocampus to develop PTSD. But nothing like that yet in BPD.
There is a third possibility, which is that neurogenesis is decreased, right? I mean, this is, in the field of neuroscience, we're really always amazed at how much we're in kindergarten, because when I was training in medical school, we didn't really believe that adult neurons divided. That turns out to be wrong. Adult neurons certainly divide in the hippocampus and possibly in other areas of the brain. So another possibility is it's an imbalance between neurogenesis and neural destruction. And the hippocampus in particular is vulnerable to that, because that's the area in which the greatest turnover of neurons exists in the adult human brain. So, we don't really know, but we know nothing. Nobody really has done studies looking at the longitudinal course of hippocampal size in borderline personality disorder. It simply hasn't been done.
Since borderline personality disorder patients tend to dissociate, how can treatment target the dissociation to improve the prospects for a therapeutic outcome?
I mean, treatment can target two things. Treatment can target situations that trigger dissociation, like traumatic re-experience or whatever, ongoing traumatization or whatever, that triggers dissociation. Of course, that can be target of treatment. And the other thing is to teach the patients anti-dissociative skills, as already mentioned, so to teach them how to stop dissociation. These are the two options, and for example, DBT treatment combines both, so they reduce the probability to dissociate, and on the other hand, to teach skills that people can learn in everyday life to reduce dissociation.
Is there any research on the use of deep brain or vagal nerve stimulation in affecting the function of amygdala or other areas of the brain that affect emotion? I think we earlier had one about neural feedback, which has been used also for EEG studies, which is another way of possibly affecting brain function that's been used in traumatic brain injury. Any comments on these kinds of treatments?
Deep brain stimulation has been studied primarily in depression. I don't know of any studies in borderline disorders. And two areas have been studied. They've stimulated what's called Area 25, which is an area at the very front of the anterior cingulate. And Helen Mayberg has done this work with people who had intractable depression and found very impressive results. The first study had about 8 patients where they turned on the stimulation. They implanted a kind of a pacemaker that would keep stimulating that area. And they could turn the pacemaker on and off in a kind of double-blind way. And they found that when they turned the pacemaker off, the patients experienced the depression again. When they turned it back on, the depression resolved. And there's a German group which has been stimulating a different area of the brain, the nucleus accumbens, which is an area that's involved in pleasure, and also found that stimulating that area was effective in treating depression. And interestingly, the behavioral findings that this group found is that when that area was stimulated, patients reported a kind of desire to do the fun things that they used to like to do. They found sort of the motivation got activated, whereas when the anterior cingulate area was stimulated, the change was more sort of in the immediate affective experience. So there certainly is a potential for deep brain stimulation in psychiatry. Obviously, this is neurosurgery. This is not something one enters into lightly, but borderline conditions can be extremely intractable to treatment in some patients and extremely life-threatening. So I think this is an area that could be pursued. Yeah, it would be, the amygdala would be a little bit hard to reach. You need a really talented neurosurgeon to kind of get down to that area. There are some other techniques also that have been used in looking at depression, transcranial magnetic stimulation, which is a way of placing a very powerful electromagnet on the surface of the skull and creating an oscillating magnetic field which can induce electrical changes a few centimeters down in the brain. People have looked at that as a treatment for depression. That's very far from the amygdala, but you might be able to trigger circuits that connect up to the amygdala. The findings with transcranial magnetic stimulation are kind of mixed.
But wouldn't you probably more logically target, not perhaps Helen's area, but regions of the anterior cingulate, and you could do that, and certainly even in a regulated way, in a sort of science fiction manner, you could imagine control of rage attacks, given the, again, it's not something we would think about in an ordinary clinical situation, but given some of the work even by the MGH people and triggering of aggression and critical brain regions, you could imagine using some of these stimulation or the magnetic techniques to modulate in an ongoing, even real-time way, the activities of these brain systems. Whether this would be feasible or desirable is another question.
Yeah, I mean, I have to say the amygdala, targeting the amygdala as a site for stimulation in general in animal and cat studies, I mean, they become terrified and bite. So it's not something, I mean, not only do we not yet have a particular site that has been widely replicated. I mean, I think Robin Area 24 has been pretty widely replicated. It's a site that's small in borderline personality disorder, but not necessarily so much underactive. It's underactive in different circumstances. But I think we could, that would be a possibility. But the amygdala, even if we could get there and even if we had a reliable signal, it would be the place I'd avoid if I were doing any stimulation.
Let me just say one thing about that. You actually can downregulate areas by stimulating also, so that if you stimulate at a certain frequency, it increases the activity. At another frequency, you can actually decrease the activity. So in theory, you could decrease the amygdala if you want a chance going into that region. But I think the area that Larry was talking about, the rostral anterior cingulate is certainly a more accessible area, and that area is about the same size or larger than the area Helen Mayberg is stimulating. So I think one might be able to approach that area.
The other possibility is that you could use these feedback systems possibly to, in the context of functional MRI, to actually use the amygdala hyperactivity as a readout and directly feedback on relaxing or decreasing activation of brain regions, although I don't know that would be any more specific than physiologic measures that might correlate with the same thing. But anyways, these are, I think, rather far-reaching and not quite ready for prime time kinds of treatment thoughts. But I think on that note, we're really approaching the end of our conference. I wonder if Carrie wants to make a few closing remarks.
I want to thank this outstanding panel, interesting, probably the best brains in the world talking about our brains. So I want to thank you all for coming and doing this for us. Tomorrow our focus will be on treatment. We look forward to seeing you all at 8:30, and you'll also hear from our family members and consumers and a little research on some family work. So thank you for coming. We look forward to seeing you tomorrow.